little brief overview about safety plans and self-harm. And we will have questions. Please feel free to ask any questions in the chat, or else at the end of the talks, we can go through everything there as well. Okay, so first of all, I'm going to touch on self-harm, what it is, and then I'm going to overview safety plans. So I'm going to look at some of the evidence, the policy, and then the practice. Then I'm going to hand over to our speakers. Okay, so first of all, when we talk about self-harm, what do we mean? And we get a lot of questions actually over the definition of self-harm. The definition that we use is self-poisoning or self-injury, irrespective of apparent motivation or medical seriousness. So this is the definition that's used by the NICE guidelines. And it includes, so people with suicidal intent, they're included in this definition as well. It's a very common reason for hospital presentation and indeed for any health services presentation. So in England, there are around 200,000 episodes each year for self-harm, and that's by around 150,000 people. Now that's likely to be an underestimate given the increases that we see, particularly around youth self-harm. But just to say, this isn't just an issue amongst young people. We've seen rising self-harm rates around midlife. So Caroline Clements, who's on the call, did an outstanding paper on self-harm in middle-aged men. And then we've also seen rising rates in older adults. And indeed our session next month is focused on that. Okay, so we know what self-harm is now, we're clear about that. So on to safety plans. Most people will have heard of safety plans now at this stage. They're becoming much more widely used across health services. So I'm just going to give you an example. So this one here, and I'm again going to touch just briefly on it. So this is a safety plan that was developed by Barbara Stanley and colleagues. And I'm just going to touch on some of the things. So like they give warning signs and coping strategies. But we've also developed a safety plan. We've called it a wellbeing plan for our public involvement, and our public contributors felt it was a really good idea to co-design this wellbeing plan to kind of manage safety. So they have a lot of acceptability for patients and for staff as well. So what about the evidence? And again, we have experts on safety plans here, so I'm going to just touch on it briefly. There's surprisingly little evidence on safety plans for people who have self-harmed. A lot of the evidence is focused on suicidal behavior. So this study was published in JAMA Psychiatry, very, very high impact study. And they looked at a safety planning intervention, not just a safety planning intervention, it had a follow-up part of it as well. Large study, 5 intervention sites, and then they had control sites where they looked at the case records for people. So what did they find? Quite a busy slide. This is from the paper, so I'll explain it, okay? What they found was, when it comes to suicidal behavior, that this safety planning intervention, the people who received it had lower suicidal behavior within 6 months, okay? So they engaged in less suicidal behavior. Now, what's also interesting is the people who received the intervention, they engaged with follow-up care more. Now that's important because we know that engaging with follow-up care can reduce risk of further self-harm and suicidal behavior. But it didn't work for everybody, and it didn't work for people with bipolar disorder. So that individualized care is really, really important. So then we have some systematic reviews. And again, these are focused on suicidal behavior. So this one here, the safety planning type interventions, there was only 6 studies that made it through to the meta-analysis. And they focused on suicidal behavior, there wasn't really any available studies for self-harm. But what they found was that, again, these safety planning interventions were beneficial for helping to reduce suicidal behavior. This review here by Ferguson was of the safety planning intervention that we talked about there a second ago, the one that was developed in America by Barbara Stanley and colleagues. And they looked at quantitative studies and qualitative studies. And what they found was that they were beneficial for reducing suicidal behaviour. They were also acceptable and feasible to staff and to patients. Okay, so the research would indicate that safety plans are beneficial for helping to reduce suicidal behaviour, but very little research around self-harm. So what about policy then? What about clinical guidelines? Well, I'm sure people here will probably be aware the NICE guidelines are currently under consultation. In fact, they should be published really soon, the final version, and they recommend safety plans. So this is from the guidelines, and they say that staff should consider developing a safety plan in partnership with people who've self-harmed. Then it gives them more details about what the safety plan should include. Now, what's really, really important to highlight here is that the process matters. So there's always a possibility that because safety plans are a low-cost intervention that can be given to everybody, and given the challenges that people have in accessing services, you can have an intervention that you can do with somebody, but there's a danger that they can become tick box focused and just another kind of add-on. Thankfully, the NICE guidelines strongly recommends that when safety plans are conducted, they're collaboratively done and compassionately. And we know from our own research on assessments that the active ingredients, the things that matter to people, tend to be those process elements. So the having the humanizing care, collaborative assessments, the space and time to talk about what matters to them, compassion and reassurance that the person is doing the right thing and seeking help. This is really important for safety plans, that when they get help, so when they write down something in the safety plan where they want to seek help in a crisis, that help is available. Okay, so now I've done a very, very brief little whistle-top tour of safety plans.